Hi Therese, how are you?
I'm good, thank you.
My name is Hiraya and I'm here to complete a neurological assessment with you. Is that what you've come here for?
Yes, Raya.
Okay, perfect. So before we begin, I'm just going to sanitize my hand just to make sure I don't pass on anything to you. Is that okay?
Yes.
Okay, perfect. Okay, Therese, so before I begin the examination, I always like to let my patients know what I'm gonna do first, and then I typically explain what I'm doing throughout the process so that they're with me and they're participating with me the whole time. And that's just the way I do things. I find it works really well when the patient knows what's happening. So that's just my style. So before we begin, have you ever had a neurological exam before?
No.
Okay, all right. So I'm just going to explain what it is and what it involves. So the neurological exam is essentially examining how the brain, the spinal cord, and its nerves function. Particularly, so the nerves are responsible for the communication between our brain and our muscles. So it tells us to move our muscles a certain way, to smile, to talk, to swallow. And a lot of these exams we've already done in one of our previous videos called the cranial nerve exams. In fact, the cranial nerve exam is actually a part of the whole neurological exam. But in this case, we're actually going to forgo that. We're going to put that aside because it's already lengthy as it is, and people can just watch that video on their own, which I'll link at the very end of this video. Okay, so briefly before we begin, part of the neurological exam is testing a person's cognition to see if they're fully there, if their cognition is intact. Okay, next we're going to test a few things like your ability to sense things, to feel things. So I may use a tuning fork to see if you can feel the vibrations. I may touch you with a sharp object and a dull object and ask you to identify which is sharp and dull throughout your body, so that way from head to toe, so that way we get a sense of how the nerves are working in those parts of the body. Okay, do you have any questions so far?
No.
Okay, so if you have any questions throughout the exam, or if you feel tired, if you need to pause, you can always do so, because it is a lengthy exam. We're going to go from the head to toe, so examining everything. The other thing that I let people know is why we are doing this to begin with. Okay, so the neurological exam is usually used to assess and distinguish between certain conditions. So in this system, there's the central nervous system that we're assessing, which includes the brain and the spinal cord, and the peripheral nervous system, which is everything else apart from that. So the nerves that come out of your spinal cord, there's something called the brachial plexus, the sacrolumbar plexus, and those are the nerves outside of it. The cranial nerves are regarded as the peripheral nerves, which we've already tested, and it also lets us know if we're testing, it helps us distinguish what type of conditions we are looking at when we see certain symptoms. For example, in a case of someone who had a stroke or a transient ischemic attack, so there's not enough blood flow through the brain for some reason, whether a blood vessel was occluded or it actually bursted, and they would get certain signs like facial drooping, slurred speech, so they won't be able to control one side of the face. And we call that an upper motor neuron lesion. And then there are some conditions that have similar symptoms, like, for example, Bell's palsy, which is not as lethal or not as an immediate concern as a stroke, which is called a lower motor neuron lesion. And so when we're testing these nerves, we're actually trying to see, okay, so is it involving the upper motor neuron lesion? In this case, would it be a stroke? Or is it the lower motor neurons, in this case Bell's palsy? And that could save someone's life. So neurological or diseases that affect the nerves, such as myasthenia gravis, multiple sclerosis, Parkinson's, diabetic neuropathy, those would fall in either the upper motor neuron lesion, which is a lesion in the brain to its from the brain to the spinal cord, or from the brain to the brainstem, or a lower motor neuron lesion, which is usually the nerves exiting from the spine to the muscle. So depending on where the damage is, that's where we'll see the different types of symptoms. That I know it's a lot. Is that something that you're okay with? And I'll explain more as we go. So if you haven't fallen asleep yet because of my long lecture, yeah. Okay.
Say that sentence again. Go back.
Yeah. So.
Is there anything? What was it?
Oh yeah. So, I guess what I was saying is that, do you have any questions so far before we continue with the exam?
No.
Okay. I know it's a lot of complicated terms, but I'm gonna explain what I'm doing as we're going, so that you have an idea of why I'm doing certain things.
Okay, Araya.
Okay, perfect. So let me just actually open up the file here. Some of my notes have not printed well, and this is also a very detailed exam, so I'm going to keep referring to my notes. So I hope that's okay, because I don't have everything memorized as much as I'd like to. Some of them are very precise. Okay, so the first thing we're going to do is, yeah, we're going to start with just making sure that your cognition is intact. So can you tell me what month it is?
November.
Okay, what year it is?
2023.
Okay, and your name?
Therese.
Okay, and can you tell me what city you're in right now?
Toronto.
Okay, so off the bat I could tell that this person is oriented to person, place, and time. If there was any concerns about that, then we can continue ahead with the mini mental exam, which I have here, which tests further someone's ability to recollect certain memories, or do basic math and everything. But we're going to forgo that and continue ahead with the exam. Okay. So I'm actually going to need a few tools here. I'm just going to place my computer down here beside our clinic cat. Okay. Alright. So the first thing we're going to look at is the muscles. Okay, so I'm just going to look at your Are you able to pull your sleeves up? Okay, so I'm looking at the patient's musculature. Yeah.
Do you need the other one?
The other one too as well, because I'm trying to compare how they are from both sides. If one side is larger than the other, that would give us some indication of what's going on. Again, trying to determine if it's an upper motor neuron or a lower motor neuron lesion. Okay, I'm also looking for any limitation in the person's range of motion. In this case, they're doing what is considered activities of daily living, which is dressing, which is why we just let them do it themselves. Okay, so I'm going to I'm going to measure the muscle groups. So, and then we're gonna write it down on this little notebook here, just to see that they are in fact equal on both sides. this down here for now while I do that. So we're going to start with the biceps. So I'm just going to take this ruler. So we're just measuring the bicep when it's not flexed. Alright, so let's gonna write that down. Yep, I can actually clip that here. That's probably better. idea. Alright, so the right bicep. Centimeters. Okay, good. Okay, I'm gonna do the same thing on the other side as well. So the reason why we're doing this is in certain conditions, like for example, when someone has had a stroke, they're gonna lose they're gonna lose control with one side of the body, usually the opposite side of where the stroke happened. And because the stroke is an upper motor neuron lesion, in the beginning we're going to see some muscle wasting and some spasticity. Okay, so that changes the size of it. Okay, in this case they're equal for the biceps. I'm also going to do that for your forearms as well. So here we have the brachioradialis muscle that we're measuring. Okay. Okay. So I'm just gonna write that down again. So brachioradialis. Left, right. Okay, so they're equal bilaterally. Alright, so I'm going to also test, are you able to expose just the thigh muscle here? So there's a group of muscle here, the quadriceps is what they called, and also the hamstrings in the back. Alright. Okay. And this other one. Oopsies. Okay, I have to make sure that I measure in the same level, otherwise we're going to get a different reading. Okay. Okay, so there's a slight difference between the left and the right here. So the quadriceps on the right side. So 1 centimeter more than the other one. And when that's the case, I then work my way down just to see if it's consistent with the rest. So I'm going to measure your gastrocnemius, which is the calf muscle. Okay. Okay, so the calves are the same. Alright, have you had any issues with one side of your legs at all?
No.
Okay, okay. Certain, okay, so certain discrepancies is normal, and as long as it's not causing any pain or anything at all.
No,
okay.
right.
Do you have a question?
No.
Okay, alright, so So we're gonna continue with a musculature examination. Okay, so all right. So I'm going to test your range of motion. Okay, that means your ability to move your joints in where we expect them to be able to move. Okay, so because I don't have this memorized, I'm gonna look into my computer to make sure that we are on the right track. So, alright. Okay, how am I gonna do this? Let me. Okay. Okay, so, alright, so first we're going to test what is the. Oh, that's okay.
Oh.
Yeah. We're going to test what is called the active and passive range of motion. So first we're going to test your ability to do it by yourself, and then we're gonna test it against resistance. So I'm gonna apply an opposite pressure with my hand, and then that's what we'll do. So the first thing is we're going to tuck your chin and look down. Okay. So this is looking at the C2 nerve root, and then going up again to the ceiling. Okay, this time we're going to come back to the normal and take the right ear to your right shoulder. Okay, this is C3 nerve root, and then to the opposite side. Perfect. And then come back to center. Here we're going to shrug your shoulders. So for those of you who's watched that cranial nerve exam, this is the accessory cranial nerve 11, but in this case it's also the C4 nerve root. Okay, if you're able to take your arms out wide as if you're gonna hug someone, this is shoulder abduction. Okay, and
Oh, right. My right shoulder is a bit stiff. So this one I can go all the way.
Okay.
This one not so much.
All right, so we'll take a note on that. And is there something that you know why that what could have caused it?
Just by sleeping on it too much.
Okay, so it sounds like a mobility issue. Okay.
Very recent.
All right. Okay. All right. So we'll have a look at that. Are you able to kind of like take your wrist like this?
Yes.
Exactly. Okay. And bring them down. Okay. Open your fingers. Okay. So that was C6, C7, and C8. And T1, finger abduction. So if you're able to bring them, take that, this is out, abduction. Okay, C8 is thumb extension, so giving me a thumbs up. Okay, all right. Okay, so we're going to do that with me applying pressure against resistance. Okay, so we're going to start again with a C2. So I'm just going to place my hand on your forehead. Okay, I'm just going to sanitize one more time just to make sure before I touch you. Okay, all good. So all right. So these are what are called the upper myotomes. Okay, come back. Okay, so I'm going to do that again, this time against resistance. Okay, so I'm going to just place my hand on your forehead, and if you could try to look down to your shoe. Okay, good. I'm going to place my hand to the side. If you could take your left ear to your left shoulder. Okay, good. And then the other one, I'm going to place this here. Perfect. Okay, I'm going to take, if you're able to shrug your shoulder. Okay, good. And then the other side. Perfect. Okay, so this is the tricky one for C5 on the shoulder abduction. We're going to do it one at a time because I want to see the difference. Actually, we're going to do it together and I want to see the difference in strength. So if you're able to take your arms kind of like this. Okay, is this okay?
It's okay.
Better than fully all the way. Okay, good. So I'm going to test a downward pressure on this. Okay, and then an upward pressure. Okay, good. So they're actually equal in strength despite the joint limitation. So that suggested that nerve root is intact, which in this case is C5, C6, and C7. Okay, so I'm just going to put this computer to the side here. Alright, so we're gonna go to this second part. Okay, so Therese, we're going to move on to so that's the upper myotomes, okay? And now we're going to move on to the lower myotomes. So we're going to do similar movements, but this time in your lower extremities, which are the legs, okay? Is that okay with you?
Yes.
Okay, good. Okay, Therese, as I said, we're going to have a look at the lower part of your body to see if the muscles are okay. The first thing is L1, L2, which is hip flexion, which you kind of did a little bit while I was wrapping the ruler around your thigh. So are you able to do that just one at a time so you're not flying off the table? There you go.
You would like me just to lift up?
Yeah, just lift up. Okay, good. So I know what you're able to do. And then the other one. Perfect. L5, S1 is hip extension. This is normally done laying down. We're not able to do this seated, but we'll come back to this later. L2, L3 is hip adduction, so bringing your knees together, okay? And L4, L5 is abduction, so bringing them out, okay? And S1, knee flexion, so bringing your heel to your buttocks, yeah. And L3, L4 is knee extension, so as if you're gonna kick out, okay? L4, okay. L4 is ankle dorsiflexion, so as if you're pressing on the gas pedal, okay? And L4 ankle inversion, so that means turning them inwards towards to face each other. L5 is big toe extension, so giving me a thumbs up with your big toe.
Well, that's a bit harder, right?
Yeah, that's okay. Or just bringing all the toes, okay? S1 is plantar flexion, so bringing as if you're about to go on your tippy toes. There you go. So the other one is dorsiflexion. L4 is actually the opposite. Perfect. And S2 is knee flexion. Which I thought we did. Oh yeah, S1 and S2 is knee flexion. Okay, good. So I'm going to repeat that this time with my hands trying to stop you, okay? So I'm just gonna place this here to the side here and put my pen here. All right, so let's go with L1 and L2, which is hip flexion. So I'm just gonna place my hand here. Are you able to? Okay, good. And then the other one, so equal strength. Hip extension. So are you able to lift this up and then try to bring it down? Perfect. And then the other one. Good. Hip adduction. So bringing them together, knees together. Perfect. Abduction and apart. Okay, good. S1 and S2 knee flexion. So against my hand. Perfect. And knee flexion extension should be L3, L4. So this way. Okay. L4 ankle dorsiflexions. Okay. Ankle inversion for L4. Eversion L5 S1. Big toe. Okay, perfect. Okay, and I'm going to ask you to go on tippy toes here. Okay, and perfect. So that's good. So you did well in all these exams. So despite your shoulder being limited, you were able to perform all the exams with equal strength bilaterally, which is what we want to see. That means the nerves are intact. Okay. All right, so we're going to move on to the next exam. All right, so thank you again for going through those tests with me, Therese. Okay, so the next thing is passive range of motion. We're going to apply some movements in your joints once again. This time with me doing all the work, all you gotta do is, let yourself loose like a rag doll. And I'm going to see if they move in their expected range of motion. If there's any pain or discomfort during this examination, please let me know so we can pause or stop the exam entirely, okay? All right. Okay. Okay, I'm just going to, okay. All right, perfect. Okay, so I'm gonna start with your arms here. So the same thing that we did. So I'm gonna start with the elbow joint. So just let yourself be loose, okay? And I'm gonna do elbow rotation. Any issues there?
No.
Okay, abduction and adduction. Okay, now is this okay? Elbow. Sorry, that was the shoulder joint, or the glenohumeral joint is what it's called. So here, flexion, extension, a little bit of circumduction, that's okay. Pronation, supination. At the wrist joint here. Okay. And with fingers, flexion, extension. Okay? Okay, that's fine. And then go to the other side. So this is a bit problematic. Okay, so I'm going to see how far we're actually able to go. When you feel the discomfort, let me know, and that's how I'll know. So there's a test called the Reflex arc where we actually abduct the arm out. Is this okay?
There, right.
All right. Okay, at the front over here on flexion.
Right about there.
Okay, and in extension, I'm just going to come back here and see if you're able to bring this back this way.
A little bit.
Okay, so that's a little bit more mobile. Okay, and if you come back, I'm going to just do a little bit of rotation. Is this okay?
No, because then it starts to hurt again.
Okay, all right. So we'll leave that alone. We'll focus on the elbow joint here. So this is okay. Flexion, extension, pronation, supination. Okay, here as well. And the joints here are also okay. All right, so for the knee, I'm just going to flex and extend. Okay, so just let yourself be loose this time. Okay, so All right, so I'm gonna just text the passive range of motion
Mm-hmm.
off the lower limbs. Okay, so ideally, again, we're doing this supine, but because we have another resident on the bed, we're sharing with yeah, someone else. Okay, so I'm just going to do the hip flexion here and extension. Okay, and the other one. Flexion, extension, internal rotation, external rotation. So for the knee, flexion and extension. Here we go, extension and flexion. At the ankle joint, dorsiflexion, plantar flexion, eversion, inversion and eversion. Same thing here. Dorsiflexion, plantar flexion, inversion, eversion. Any issues there?
No.
Okay, good. So it sounds like it's just the right shoulder. So had there been an issue with a myotome strength there, then that would indicate that there is a problem with the that could give us a clue that the nerves could be involved, and then we'll test sensation. But in this case, it's more sounds like either a joint musculature issue. Sometimes with people who have osteoarthritis, when their joints, especially in ball and socket joints, there is a cartilage that protects that bone, so that's not bone to bone contact, it's bone, cartilage, and then cartilage, bone. Over time, the cartilage can begin to erode, and cartilage is very difficult to heal because it's not as vascular as bone. When you break a bone, you can cast it and it'll start to connect the blood vessels and thus come back almost the same way it was before. But when you damage a cartilage, because it doesn't have a lot of blood vessels, it's very hard, almost impossible to come back to its normal. So when people over time, through wear and tear of use, that cartilage begins to disappear, and that bone-to-bone friction is what causes pain in osteoarthritis. Now in your case, it's important to distinguish whether or not it's osteoarthritis or is it a frozen elbow because of you said malpositioning. Someone who plays tennis, for example, someone who's constantly using this all the time, like someone who does drywall, for example, that's someone who would be more likely to get osteoarthritis. So it's also important to ask about the patient's occupation, because oftentimes that's where we do repetitive movements and thus get repetitive injuries. Okay? All right. So we'll move on to the next exam. Okay, good. So we just tested a passive range of motion. I was looking for any flaccidity, rigidity, or spasticity, which would be seen more or so less in certain upper motor neuron lesions or lower motor neuron lesions. All right, Therese. So it looks like both your myotome, both the upper and lower myotomes are intact. Thank you so much for doing that exercise with me. Next, we're going to go on to the next exam, which is the cerebellar function. The cerebellum is a part of the brain that is located at the base of the back of the head, along with the cranial nerve number 8, which we tested in the other video, vestibulocochlear exam, because the ear is also responsible not just for hearing but also balance. The cerebellum's main function, one of its main function, is balance. Okay, so normally this exam includes the person walking around the room, so I can see how they're walking. Their gait is what it's called, in different ways, such as tiptoes or on their heels. But because we don't have a lot of room here, we're going to move on to the Romberg's test. okay, which is going to involve you standing up with your eyes closed to see your balance and coordination. And from there, we're also going to do the what is called the knee bend test. And while you're here with your eyes closed, we're going to do an exam called the pronator drift, okay? All right, so if that's okay with you, if you're able to stand up and bring your feet close to each other, perfect, and arms to the side. I'm just going to place my arms around you to catch you just in case you fall, okay? And from here, if you're able to close your eyes and try to maintain stillness. Perfect. Okay, you can open your eyes again. And if you're able to take one knee up, the left knee up.
Okay.
Whichever is up. Okay. And then the right knee. Okay, great. Okay. And then you can sit back down. Okay, and from here we're going to test the pronator drift. All you have to do is take your arms out like this with your palms up and close your eyes. I'm just going to apply gentle tapping pressure here. Okay. Alright, so if this was positive, you would feel the need to, or the breaker radialis will supinate and pronate your arm. In this case, it didn't do that, so it's a negative. And if it was positive, it would be indicative of an upper motor neural lesion. Okay, good. So we can move on to the next series. Okay. Alright, so I'm going to move on to the next exam. Alright, so here's the fun part. It's called the coordination and skilled movements. Are you doing okay? So this is the rapid alternating movements. If you've ever played, you know, pat a cake in kindergarten when you're young, and then you basically do hand motions, so it's similar. So I'm going to have you basically pat your knees with both hands. Okay, so you're just kind of like moving them, okay, and then you're gonna do that a little bit faster, okay, faster, and fast. Okay, that's good. That's good now, okay. So both of the coordination seems good there. So now I'm just going to ask you to touch your finger to my finger here, and then touch your nose with it. Okay, and then finger to nose, finger to nose, faster. Okay, a little bit faster, good. Okay, perfect, and then the other one. Good. Alright. Perfect. Okay, perfect. So what I'm testing there is cerebellar diseases, or as I said, damage to the cranial nerve number 8, vestibulocochlear, and that would be called dysdiadochokinesia. Okay, we also have to do this for your feet as well. But before we do that, let's just make sure that I've covered everything that we need to do to the top part of the body, so we're not going up and down. Okay, so there's no dysmetria. You're not missing the finger. Oh, okay. In this case, are you able to close your eyes? This is called the finger to nose test. And take your index finger to your nose. That's right. Okay. And then the other one. Perfect. Okay, so now we can move on to the lower part of the body. All right, Therese, so now we're going to move to the lower part of the body. Okay, so if you, similar to the pat a cake, we're going to do that with the feet, except you're just going to kind of like tap your sole of your foot to my palm here. So if you're able to do that together, and then one and the other. Okay, faster. Okay, and then together. Fast. Good. Okay, perfect. Good. The other thing here is the heel to shin test. Normally this is done laying down. In this case, I'm going to have you extend this knee. If you bring it up, are you able to take your heel and bring it to your shin? Feel free to like support yourself so you don't
flexibility like that?
Over here. That's going above and beyond. So just touch your heel to the shin if you're able to, and then bring the heel out. Okay, and then back, and then slide it down to the leg, and one more time, and down. I know this is not a Pilates class you signed up for, but try to do it with the other foot again. So I'm testing essentially the coordination here. If the patient's able to do it, in this case they are. Perfect. And if they're not, then it would indicate, it could indicate cerebellar diseases. Okay. Alright, so here's the fun part. Okay, we're going to move on to the sensory system. Okay. Actually, while we are down here, we're going to work our way down to up in the sensory system. Here I'm going to poke you with something a little sharp, but it's not going to pierce your skin. And I'm also going to touch your skin with something dull, and I'm going to ask you to essentially distinguish whether it's sharp or whether it's dull. Okay. Okay, so if you really nice feather. Okay, so if you close your eyes, if you just give me your forearm, I'm gonna, or you can look. So this is what sharp feels like. Are you able to tell the sharp? Okay, and this is how dull feels like.
Okay.
Okay, so if you're able to close your eyes. Alright, so I'm just gonna touch this part of the leg.
Sharp.
Okay.
Sharp. Dull. Dull. Sharp. Sharp. Dull. Sharp. 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 Dull. Dull. Sharp. Dull.
Okay, perfect. We're also going to do that to the upper part of the body, but since we're here now, I'm going to test the temperature sensation. So we have here a little warm, and we also have the ice cubes. Okay, so if you give me your forearm, I'm gonna let you know what kind of cold feels like. I mean, are you able to feel that?
Yes.
Okay, and okay, this is what warm feels like. So you're able to tell the difference. Okay. So if you close your eyes, I'm going to do that in your lower extremity. Okay.
Warm. Warm. Cold. Warm. Warm. Cold. Warm. Cold. Warm. Cold.
Okay, thank you so much for doing that. Okay. So now we're going to test whether or not you're able to feel things simultaneously on both sides. Okay, so I'm going to take another cotton ball. So I'm going to do it on your arm. So this would be both, and this would be left. Okay, and this would be right. So you'll tell me which side it is.
Okay.
If it's both, or is it just left or right?
Okay.
Okay. So if you close your eyes again, I'm going to do it in your lower legs. Okay, so
both. Left. Right. Both. Both. Left. Right. Right. Left. Both. Left. Right.
okay, perfect. Thank you. You got that all correct. Okay. Next, we're going to do it with a tuning fork to see if you can feel vibrations. Alright, we have a 128 hertz tuning fork here. I'm going to start by showing you what vibration feel like. So if you feel this, you'll say that it's vibration. So I'll put it on your chest. Normally this is where it's put.
Yes.
You feel that vibration? Okay, so this is what it would feel like when it's stopped. So can you tell the difference between vibration? Okay, so I'm going to do that in your lower extremities. So if you could close your eyes. Okay, I'm going to start with the most distal.
Yes.
Okay.
No.
Okay.
No.
Okay.
Yes. No. No. Yes. 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 No.
Okay.
Yes. Yes.
Okay, good. Perfect. Okay, so I'm just gonna record some of the findings here. Okay, so just so you know, some of the, especially the vibration sends, were not detected. It's a more finer sensation, and those sometimes happen either in certain conditions where there's either nerve degradation, or there's the nerve is covered by what is called a myelin sheath. So in certain conditions like multiple sclerosis, those myelin starts to erode. In certain neuropathies like diabetic neuropathy, the sugar molecules begin to scratch the nerves because they're quite sharp. They're kind of like a hexagon shape. So imagine like little shards of glass traveling into the bloodstream. And the damage in the nerves eventually leads to the loss of sensations in those nerves. Okay, so that's why we test first with more denser objects, temperature, and then finer things like vibration. Okay. So, okay. Position kinesthesia is next, which tests the person's ability to perceive passive movements of extremities. Okay, moving the toe up or down. Okay, so for this one, I'm going to demonstrate on your hand. So if you take your hand, just face down, this would be up and this would be down.
Okay.
Okay? Up, down. Okay, so I'm going to do the same thing on your toes here. Okay.
With my eyes closed, right?
Yes, with your eyes closed. Okay, so I'm just going to take the feet, grab the toe here. Okay?
Up, down, down, up, down, down, up, up, down, down, up.
Okay. Another one.
Up, down, up, down, down, up, up, down, up, down.
Okay, so you're able to get all of those correctly. Okay. I think I've had you do the heel to shin already, so you passed that successfully. Now moving on to the sensory system. Oh yeah, we did the sharp and dull already, temperature. Sorry, my page went back to previous. So, fine, okay. A Hoffman sign, okay, that's for the upper fingers. Tactile discrimination. Okay, okay. Alright, so the rest is for the upper, but we can also do what is called a 2-point discrimination on the lower extremity, because that's kind of what seems to be more of a it's less easier for people to detect. So I'm going to take this paper clip essentially and make two pointy parts of it. So if you give me your hand, you'll feel, are you able to tell that there's two pointing? Yes. So this is just one. So this is two, correct? Okay, so we're going to do that on the feet with your eyes closed. Okay, so
Yep.
are you able to feel this?
Both, yes.
Two.
Yes, two.
Okay.
One,
Okay.
two. One, two, two, one. One. Very light. Again, please. One. Two. One. Two.
Okay, good. Thank you so much. Alright, so how are you doing? Do you need to take a break?
I'm okay for now.
Okay, are you sure? Okay.
Yes.
Because that
Oh, we have to do the lying down. Is that correct?
We have to do the upper part of the body, but I just want to make sure I do everything in the lower, so we don't have to go up and down, up and down. Okay, so extinction is simultaneously touching both sides of the body at the same time and asking how many sensations were felt and where they were. We did that, okay? Graphesthesia is reading a number traced on the skin. Usually we do this on the palm, so we won't do that on the sole of the feet, but what we do at the sole of the feet is something called the Babinski reflex, with a reflex hammer. So we'll get to the reflexes eventually, I promise, but if you give me your feet here, and I'm just going to basically stimulate the sole of the foot. Okay, yeah, that's okay. That's a normal response, is the toes curling in. Okay, and we're gonna do that. My apologies if that was unpleasant for you, but I'm gonna be a little bit more gentle. Okay, good. So you notice that the toes curled in. If the toes were to fan out, that would be a positive Babinski, and that would indicate either an upper motor neuron lesion, or in infants, usually less than 1 year old, it's normal. Okay, an upper motor neuron lesion that's very concerning with a positive Babinski is called meningitis, which is infection of the meninges of the brain or the spinal cord, and with that we'd follow it with a test called Brudzinski sign. With that we'd follow it with a test called Brudzinski or Koenig sign, which is done laying down, which in this case is not available to us. Luckily that's okay, so we won't do anything more with that. Okay. Alright, so the next is reflexes. Alright, Therese, thank you so much for allowing me to assess your lower limbs. As I said, we're going to move on now to the upper limbs. So I'm just going to make sure that we've gone over what we needed to do here. Okay, so we did the rapid alternating movements, finger to nose test, heel to shin. Okay, we did the sharp and dull on the lower extremity, so now we're gonna do that on the upper extremity. Okay, perfect. So over here I have this box of quill and some cotton balls, and this is what we're going to use for the tool. Okay, so here we're testing your pain sensation in the spinothalamic tract. The sharp object is not going to pierce your skin, but I just want you to get a sense of the sensation of what it feels like. So I'm just gonna test it here on your forearm here. So this is sharp, as you can see, and this would be dull.
Yes.
Okay, so you're able to distinguish between the two. So if you're able to lift up your sleeves, I'm just gonna place these items in various portions of your arm. Okay, and face as well. And if you're able to tell me whether you're feeling something sharp or dull. So we'll start with the face.
Dull.
Okay.
Sharp. Dull. Again, please. Sharp. dull, sharp, sharp, dull, sharp, dull, dull, sharp, sharp, dull, sharp.
Okay. Alright, good. So because you were able to get all of those correctly, we won't need to move on to the temperature, which we did in the lower extremity because you were having difficulty distinguishing between certain sensations. Okay. Alright, so just like before, we're going to do the cotton balls, and you let me know if it's on both sides, right or left. So I'm just gonna, yeah, I'm just gonna help you move this up. Yeah, this is like your muscle man outfit. Okay, so this is how both would feel like, left and right. Okay, so with your eyes closed.
Left, right, together, both. Right, right, left, both. Left, right.
Okay, perfect, good. So now we're gonna go with a tuning fork again. So you kind of already felt what it's like. Again, I'm gonna start at the most proximal parts.
Yes.
And let me know if you feel it stop.
Yes. I mean, it's still stopped now.
Okay. Radius stylus.
Yes, still vibration. Vibration. Stop.
We'll go here.
Yes. Still vibration. No. Yes, vibration. Vibration. Stop. Vibration. Stop.
Okay, perfect. Now we're going to do the positioning of your fingers, if it's up or down. So if you just give me your hands. This is up and this is down. Okay?
Down. Up. Up. Down. Up.
Okay, perfect. The other one.
Up. Down. Up. Down. Oh, up. Down.
Perfect. Okay, so that one's all good. Now, here's an interesting one. We're going to see if you're able to distinguish common household items with your eyes closed. So I'm going to place objects into your hand and you tell me what you think it is. So if you close your eyes. Okay, can you tell me what this is? So you feel free to
A watch.
it. Okay.
Key.
Sorry, can we do that again? If you're able to just take your hands out over your chest area.
Sorry.
Yeah, there, and I'll give it to you.
Okay.
Here. Okay.
Sorry. Watch.
Okay.
Key. Like a quarter or a toonie or something.
Yeah, a coin is fine.
Paper clip.
Great, you got all of them correctly. Now we're going to, I'm going to write something. So that's called stereognosis. Now we're going to test graphthesia. So essentially I'm going to write a letter or a number on your hand, and you just let me know if what you think that letter or number is. Okay.
0.
Okay.
1. Z or 2.
That's correct.
T.
Perfect. And then the other one.
Three. Again, please. I don't know. 3 or Z?
That's okay. Yeah. And then this.
Oh, 6.
Okay, perfect. That's all good. Yeah, some are more difficult than the other ones. That was a 5, and the first time it was upside down, so I didn't expect someone to be able to guess that. That's okay. The 2-point discrimination, which is going to involve this paper clip. So again, this is, I'm just going to put it on the behind. This is 2. This is 1.
Okay.
Are you able to tell the difference?
Yes. 2.
Okay.
And then 1. Yes.
Okay, great. I'll do it here.
1. 2. 1. 2. 1. 1. 2. Sorry, 2. 1. 1.
Okay. And the rest of this?
2. 1. 1. 1.
Okay, perfect. Thank you so much for doing that. The Hoffman sign is the flicking of the finger with the thumb, which is, if it's positive, would indicate upper motor neuron lesion. And the positive would be a quick adduction of the thumb and flexion of the middle finger. Okay, so...
Am I closing my eyes for this, alright?
Yes, please. So I'm just going to quickly flick the finger with the thumb. So... Okay. Okay, good. Nothing. Okay. Alright, so we did vibration, position, tactile discrimination, stereognosis, graphthesia, 2-point discrimination, and I don't think we did the extinction, which is with the 2 cotton balls and doing left, right, or both. We did, I believe.
I know he did my lower extremities. I can't remember the upper.
Yeah, so just quickly, I'll just do it. So this is both. This is 1 left. I feel like we did.
We did.
Right? Yeah, we did. Okay. So moving on finally to the reflexes. Okay, so I'm just gonna test your reflexes here, starting with the biceps and the brachioradialis, which is the C5 and C6. Okay, so biceps. Oh, okay, I'm just gonna go down a bit here.
Shoulder.
Alright, so just relax. Yep. Can you clench your teeth? Okay. Brachioradialis. Okay, I wasn't able to elicit any response on that one. Let's try this one. Okay. Yep. Okay, we're gonna do the triceps. Okay, triceps C7, C8. Just let yourself loose.
Hold on 1 second.
Okay. Yep. Okay, the other one. Oh,
Okay.
we can't do this one.
Yeah.
Yeah, so let's just
I'm not good.
okay. So okay. Now we're going to do the lower reflexes. So now we're going to test the lower reflex, starting with the patellar reflex. So sometimes with reflex, there's a lot of conditions that would affect the reflexes. So for an upper motor neuron lesion, such as, for example, so for an upper motor neuron lesion, you'll usually get hyperreflexia. Okay, so yeah, so there are certain conditions that would increase or decrease the reflexes. So in upper motor neuron lesions, it tends to increase, such as in a stroke. It tends to decrease in certain conditions, like in thyroid disorders. Yes, I believe it. No, is it thyroid? I'm gonna have to look that up. Yeah, I believe in thyroid disorders. Yeah, hypothyroidism can affect the reflexes, can diminish the reflexes. So with this, if you could just start pulling your arms as if you're gonna rip your fingers off, and look to the wall over there, and just try to sing ABCs in your head. Okay, ready? Okay, and then the other one. There is a grade 2 there. Yeah. Okay, so that is the knee reflex, which is the L5 and S1 for both the knee and the ankle. The Achilles tendon again doing the same thing. Yeah, it's difficult to elicit the reflex, but there's some. Okay, are you okay? Was that a reflex or? Okay, sorry, because I was like, that doesn't seem to be coming from the right place. Perfect. So we did the we did the Achilles, we did the knee. Okay, just gonna repeat the Babinski reflex here because I'm not sure if we were able to capture it. And we will just stroke it up, and it should come down, as I said. And it crawls down, and if it were to fan out, this is a normal finding in infants, but it's abnormal in adults. In infants, they haven't fully developed their myelination in their nerve cells, so the upper motor neuron hasn't fully developed. But in adults, it would indicate an upper motor neuron lesion, such as meningitis. And if that's the case, we would have you lay down and test the Kernig's and Brzezinski's sign, which we can actually do now. So if you're able to lie on your back. So say we suspected meningitis in the positive Babinski's kind, we will do the Kernig's and Brzezinski's. So let's start with Brzezinski's because you're already almost there. So essentially what I'll do is I'll go at the head of the table here, and from your supine position which you're in, I'm just going to lift your head and flex your neck. Okay, in this case it's negative because a positive Brzezinski sign would mean an involuntary hip and knee flexion, so your knee would actually come up ever so slightly. Here we don't see anything, so that's negative. All right, so and then the other sign to confirm is the Koenig sign, which is going to involve me lifting your leg here. Okay, we're gonna lift your leg, bend you at the knee here, okay? And just making sure you're not exposed here. We're going to raise this leg up. Are you able to kind of raise that leg up?
Yep.
Okay. And the Kernig's, positive Kernig's would not allow that to happen. It would be painful to have that happen. So in this case, it's negative. Now that you're in this position, I can actually test for clonus. So Therese, now we're going to test for what is called clonus, which is this kind of involuntary movement of your muscles that we can see more accentuated in upper motor neuron lesions. Whereas if it were fasciculations, it would be lower motor neuron lesions. So anyway, I'm going to just expose the area that I need to work on. So I'm going to start with this right leg over here. And from here, I'm just going to kind of just let it be floppy. Good. And then shake it. And I'm going to just lift it up and down, up and down, up and down, and then a quick dorsiflexion. Okay. Up and down, and dorsiflex. Good. Okay, so that's negative. There's no clonus, no fasciculations. All right, same thing here. So just let it be floppy. Just going to drop that. All right, so up and down, and a quick dorsiflex. Okay. All right. Nothing over there. We try that again. So up and down, and a quick dorsiflexion. All right, and no clonus over there. Perfect. All right, so now that we've taken care of that, we're going to move on to the dermatomes. So we've done myotomes, reflexes, sensations. The last part of the sensory is looking at the dermatomes. These are individual nerve roots that come out of the spine and that travels into your torso, your arms, your limbs. Okay? All right, Therese, I'm just going to expose the area that I need to work on. Okay, essentially, I'm going to be testing your dermatomes. These are parts, these are cutaneous or skin areas where we have the sensations connected to the nerve roots. So I'm just going to expose this area here. Expose this area here. All right, so I'm just gonna run a feather, and you just let me know whether or not you're able to feel that sensation or not. Okay, so here we go over here.
Yes.
D1.
Yes. 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 Yes.
Mm-hmm.
Yes.
Good.
Yes.
Okay, so T10 here, umbilical level.
Yes.
Okay.
Yes.
Okay, now importantly on the upper limbs here, are you able to turn around on your back now this time? Okay, C5,
Yes.
C6,
Yes.
D8,
Yes.
D1,
Yes.
C6,
Yes.
D1.
Yes.
Okay.
Yes. 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 Yes.
Okay, perfect. I have to do that again on the leg. Okay, so I'm just gonna expose this part. Okay, so L2.
Yes.
Sorry, more light. Okay. L2,
Yes. Yes.
L3.
Yes. 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 Yes.
I'm gonna remove your socks here. Okay, So that concludes our exam. Thank you so much for being here today, and we'll see you in the next exam.